Hello everybody, this is Dr. Medicine RX and in today's video we'll be discussing about graft versus host disease or GvHD. So this is an immune mediated disease that occurs as a result of a complex interaction between donor and recipient immunity. So here the immune competent donor T cells, they react with the host antigens. So it has an incidence of about 10 to 80% of cases and it most commonly follows an allogenic hematopoietic stem cell transplantation. So it also occurs in cases of lymphoid organ transplantation of lymphoid cell-rich organs such as the liver, as well as transfusion of unirradiated blood. So coming to classification, it can be classified into 4 types. First is the acute or the classic GvHD, which presents within 100 days of transplantation. The second is the persistent, recurrent or late onset acute GvHD. It presents after 100 days, but it has classical clinical features of acute GvHD. And then chronic GvHD, which presents after 100 days. And the fourth one is the overlap syndrome, which presents any time post-transplantation. Coming to the pathogenesis. So in acute GvHD, the basic pathogenesis is divided into 3 phases: the afferent phase, the induction and the expansion phase, and the effector phase. So in the first phase, what happens is that the host tissues, they are primed in order to take up the transplant. So as a result of this priming, there is release of inflammatory cytokines which further activate the host antigen presenting cells, and these antigen presenting cells such as the dendritic cells or the macrophages, they again activate the donor T cells which produces pro-inflammatory cytokines and causes inflammation. So in the afferent phase, the HSCT conditioning damages the host tissues and it increases the production of inflammatory cytokines such as IL-1, IL-6 and TNF-alpha, which activates the host antigen presenting cells. And in the induction and the expansion phase, the activated host antigen presenting cells further activate the donor T cells to proliferate and secrete IL-2 and interferon gamma. So this IL-2, which is an inflammatory cytokine, it activates the T cells as well as the NK cells and further primes the macrophages to further release tumor necrosis factor alpha, which is again a pro-inflammatory cytokine. And as a result of all these cytokines coming to action, a cytokine storm occurs. And this is followed by the effector phase where the activated donor T cells, they cause a cytotoxic damage to the host cells. Coming to chronic GvHD, the pathogenesis, it is not well understood. Basically in the initial phases of the reaction, there is going to be acute inflammation and tissue immune injury that is mediated by the innate immune system. And in chronic alloreactive phase, there is going to be dysregulation of T cells and B cells, that is the adaptive immune system has a role to play, and it causes fibrosis, so the fibrotic phase. Coming to clinical features, so in acute GvHD, 3 main organ systems are going to be primarily affected. So the first is the skin, the second is the GIT, and the third is the hepatobiliary system. So skin is the first and most commonly affected organ, and it presents as morbilliform exanthem on the acral areas, earlobes and upper trunk. So within first 3 weeks of transplant, there is going to be pruritus, and this is followed by the occurrence of follicular centric rashes, which may progress to involve all of the body, causing erythroderma. And there may also be other atypical presentations that can resemble lesions of other dermatological disorders. Then in GIT, the most important complaint is going to be nausea and as well as abdominal pain and voluminous diarrhea. And in liver, in case of hepatobiliary system, there is going to be transaminitis with cholestasis as well as elevation of bilirubin. Coming to chronic GvHD, in addition to these 3 systems, we have other organ systems involvement as well. So the skin, it can show changes similar to that of acute GvHD, that is the morbilliform exanthem, or there can be characteristic sclerotic and lichenoid lesions. So the sclerotic lesions, they can be superficial sclerosis like in morphe, or lichen sclerosis like, or they can be papules, plaques and poikiloderma, or they can be deep sclerosis involving all layers of the skin. And in the lichenoid lesions, they can be periorbital or dermatomal, and they can also be depigmentation. Coming to mucosal features, so oral, we can see lichen planus like lesions or hyperkeratotic plaques, and there's going to be decreased range of motion. And genitalia, we can see mucosal lichen planus like lesions as well as sclerotic changes as well as ulceration. Coming to nail changes, there can be dystrophy, nail loss which can affect many nails, and symmetric lichen planus like nail changes. Coming to hair, there can be scarring and non-scarring alopecia, and the non-scarring alopecia is usually new onset, and telogen effluvium can also occur as a result of the chemotherapy or radiation therapy that the patient is undergoing. Coming to involvement of other appendages, there can be decreased sweating due to involvement of eccrine glands, and there can be heat intolerance. In eyes, we can see keratoconjunctivitis sicca, blepharitis, corneal erosions and photophobia. In liver, we can find changes similar to that of acute GvHD, that is cholestasis, transaminitis and bilirubin elevation. In lungs, there can be bronchiolitis obliterans as a main manifestation. Musculoskeletal features can be fasciitis, which can lead to restricted range of motion. And if thrombocytopenia occurs, it is a very bad prognostic sign. Other systems that can be involved include renal and cardiac systems as well as serositis and peripheral neuropathy. Coming to diagnosis, for acute GvHD, there is a clinical criteria that includes the skin, liver and gut, and these criteria are to be supported by histopathological findings. So it is divided into 4 stages, and the skin, liver and gut findings are also divided into 4 stages. The first stage being less than 25% of body surface area involvement with 2 to less than 3 milligrams per deciliter of bilirubin with 500 to 1000 milliliters per day of diarrhea or persistent nausea. In the second stage, 25 to 50% of the body surface area involvement with 3 to 6 milligrams per dl of bilirubin elevation and 1000 to 1500 ml per day of diarrhea. In the third stage, it's going to be more than 50% of the body surface area involvement with 6 to 15 milligrams per deciliter of bilirubin and more than 1500 milliliters per day of diarrhea. In the fourth stage, there is going to be involvement of most of the body, so erythroderma, more than 90% of the body surface area involvement, along with bulla formation with more than 15 milligrams per deciliter of bilirubin and severe abdominal pain with or without ileus as the gut findings. Coming to chronic GvHD, so this is based on 2014 NIH criteria. So at least one diagnostic manifestation in the skin, mouth, GIT, lung, fascia and genitalia, and or one distinctive manifestation confirmed by biopsy or testing of the same or the other involved organ. Coming to treatment for acute GvHD, so if there is limited cutaneous involvement, then the first line of choice is going to be topical steroids. So for facial lesions, we go for mild to moderate potent steroids, and for body, palms and sores, we go for potent to very potent steroids. Other topical agents such as topical calcineurin inhibitors, that includes tacrolimus or pimecrolimus, or extracorporeal photopheresis and phototherapy can be tried. For systemic manifestations, systemic steroids form the first line or mainstay of therapy in severe cases. So we can start with IV methylprednisolone or oral prednisolone, and we can supplement this with second line agents such as anti-TNF alpha, biologics such as the infliximab or etanercept, mTOR inhibitors, intravenous immunoglobulins and IL-2 receptor antibodies. Supportive therapy with emollients and photoprotection and antihistamines is also be done. Coming to chronic GvHD, photoprotection and avoidance of photosensitizing agents is important. It is very pertinent to reduce the risk of squamous cell carcinoma in these patients, and topical steroids and emollients should be tried to improve cutaneous manifestations, but patients of chronic GvHD, they often require systemic therapy. Antihistaminics for pruritus, and in refractory cases that do not respond to antihistaminics, we can go for gabapentin. Phototherapy with PUVA therapy or NV-UVB is effective, especially if sclerosis is not present. Then topical calcineurin inhibitors, when topical steroids are stopped or if they are causing any side effects, then as steroid sparing agents we can go for topical calcineurin inhibitors. They also improve the erythema and pruritus. And systemic steroids, they form the mainstay of treatment in chronic GvHD. So we can start with 1 milligram per kg per day of prednisone along with a calcineurin inhibitor, topical calcineurin inhibitor. And extracorporeal photopheresis in mucocutaneous GvHD, especially in sclerotic lesions, is effective. Other drugs that can be tried in chronic GvHD include hydroxychloroquine, mycophenolate mofetil, imatinib mesylate, rituximab, rapamycin, methotrexate, ibrutinib, JAK inhibitors, and histone deacetylase inhibitors. Thank you. Subscribe for more.